Good morning, everybody. Good morning, respected director, sir. I am Rachi, Professor Sharon Singh. Good morning, the chief guest, Dr. Chandrakant Lahariya, the other participant. We, on the behalf of Atal Bihari Vajpayee Center for Leadership, Policy and Governance, I and Professor Hazarika welcomes you all. On the behalf of Professor Marathe and Professor Mishra, we welcome you to the first International Summit of Management Cases. So this is a 3-day event where yesterday we had a workshop where which was dedicated for writing case methods and how to develop teaching notes. And these 2 days we are concentrating on the presentation of different cases that have been submitted. A brief welcoming to Dr. Chandrakant Lahariya. He is a medical epidemiologist, a public expert. He has a very recent book on COVID-19 where he talks about how during COVID-19, looking back and how can one be motivated psychologically and look forward altogether. So because our theme was on COVID-19, we invited him and he was very generous to accept that. So now I may request Director Sir to kindly address the audience and flag the event. Thank you, sir.
Thank you, Sakshi. I extend a very warm welcome to all the participants and delegates of the conference. I especially welcome our chief guest, Sri Lahariya ji, who has kindly consented to give the inaugural address. The theme, the COVID-19 pandemic and how to manage it. So this is a very relevant thing. We are all coping with the issue, how to deal with this pandemic. And many experts have already given comments about their experience and have brought out the case studies, which will be discussed in the due course in various sessions. So those who were not yesterday session, it is only for their benefit, otherwise it will be repetition. As the customary, we will be giving brief introduction about the activities of IIM Ranchi and Atal Bihari Vajpayee Center before moving to specific themes. You may be aware that IIM Ranchi is a 9th sibling in the galaxy of IIMs established in 2009, and now 11 years since we are operating. We started with a moderate beginning, only 44 students and only one program, that is postgraduate program and management. Today, we have evolved in such a way that close to 900 students will be there in the campus forthcoming July, August. We have the programs like MBA, which is our flagship program. We have also MBA Human Resource Management. We have started this year another program called MBA Business Analytics, and we have also introduced another program called Integrated Program in Management, which is started with the vision to catching people young and training them into managers and leaders of tomorrow. To fill the needs of faculty and researchers, we have also started PhD program, and we have executive program in the institute. what other initiatives we have taken in order to become internationally recognized? We have initiated our international accreditation program, and traditionally we say if the institution is having three feathers in the cap, it will be considered internationally well-placed institution. And in India, two of the IIMs, IIM Calcutta and IIM Indore, has already achieved that status. And so we have started our journey last year in accreditation process. AACSB and EFMD's EQUIS accreditations applications have already been accepted, and we will be starting the process of completion. So AMBA is another accreditation in which also our membership has been accepted. Apart from this, we have accreditation or recognition of what PRME, Responsible Management Program of UN, and we are signatory to that, and perhaps we are the first signatory to that. And apart from this, we have already started the excellence, Center for Excellence in the institution, and Atal Bihari Vajpayee Center for Excellence is one of them, where we have the vision to create the policy leaders who will be contributing to the country's policy making and critiquing the policy, suggesting the new policy. And this is done in the name of great Prime Minister Sri Atal Bihari Vajpayee, who has been the source for the existence of Jharkhand state. During his tenure, only Jharkhand state was created. So it is befitting tribute to the statesman that this center has been created. This center has already undertaken multiple research projects and like the school merger project, the school training program project, and other programs are being undertaken. We have also undertaken summer school, winter school, and multiple seminars and webinars inviting no less than Honorable Vice President of India and Minister of State for External Affairs for doing the seminars for this center. We have also started another center called Birsa Munda Center for Tribal Affairs. Knowing that Jharkhand is a state with a good number of tribal dwellers. In order to be relevant contextually, we have started this center, and there our main focus is to come up with solutions and strategies where tribal youth can be gain the skill to become entrepreneurs, so that there is not with too job seeking, they can be self-sustaining businessmen, and they can provide employment to others. In this step only, we have also written MOU with the Indian Institute of Entrepreneurship Development, Ahmedabad. So they are also helping us in our endeavor to create awareness in the entrepreneurship domain. And perhaps we are the first IIM which has started entrepreneurs as a entrepreneurship as a core course. Give the emphasis that entrepreneurship is important. Then we have started very recently Center for Happiness Research in the institute. you know that current pandemic has created lot of mental health issues. Even otherwise, happiness is a very important issue for the uh, entire population in the country, and we are working on the issue of intrinsic happiness, not measured through only external indicators of income and other issues through which a happiness index is generated. We are working subject to well-being, how people assess themselves being happy. And scientific research is undertaken on that. Let me also state that since we are signatory to UNPRME, today is the date of Anti-Child Labor Day. So we should also remember that this is something when we are doing entrepreneurship, when we are working, we neither employ child labor nor encourage anybody and encourage others to do. So we will be pointing out any institution or any or establishment which is using such a kind of practice, and we will try to eradicate child labor as far as possible. So this year, the World Day Against Child Labor focuses on the action taken for 2021 International Year for Elimination of Child Labor, and it is the first World Day since the universal ratification of the ILO Convention number 182 on the worst forms of child labor, and takes place at time when the COVID-19 crisis threatens to reverse years of progress in tackling this problem. So we should remember that child labor is a menace, child labor is a problem, and how to eradicate this, and how our entrepreneurs should not be blasted and covered by activities when we are doing child labor. Now coming specifically to our conference, again I say that Lahariya ji has a right to give us his time. We are very thankful to him for the activity and kind of contribution he will be making to the seminar, and all the participants and the speakers who are going to contribute to the next 2 days event. I thank all of them and say that this event should be successful. I also invite all the participants that we have launched our journal, IIM Ranchi Journal of Management Studies. If you find good contribution, please send and submit it to our journal for publication. With these words, I again thank all the team of this conference, Sakshi, Hajarika, Professor Marathe, Professor Aditya, and the teams which team members who are working in the background, who is not in limelight. I thank all of them for this contribution and invite Professor Sakshi to initiate and request Professor Lahariya for his inaugural address. Namaste and welcome, sir.
Thank you, respected director, sir, for your very kind and encouraging words and for introducing the background of IIM Ranchi and its latest developments and the steps taken by the institute to develop in the years ahead. So we would now move ahead with the formal program. And to begin with, I would like to first request Professor Sakshi to please present a memento to Dr. Lahariya, and we will be sending it to you. We'll be sending it to you very, very soon. Thank you, sir, for attending the event. As a point of gratitude from IIM Ranchi and the center, we also have a Angvastra which will also be sending it, and IIM Ranchi Angvastra, which will be sending it to you very soon together with.
Thank you very much. Thank you.
We'd also like to thank our Honorable Director for being a part of the event, and we would also like to felicitate him and thank him with a small memento. Sir, this is for you. Thank you, sir.
Thank you, sir.
So moving ahead, we are looking forward to hearing from Dr. Lahariya soon. Just before that, we would like to request Sakshi to give a small introduction about the steps which we have taken, about our workshop and about the summit.
Thank you, Professor Hazarika. Thank you so much, sir, for giving such a nice introduction about IIM Ranchi. I welcome again Dr. Lahariya to our event. So this is a 3-day event that we have done so far, and yesterday we had a workshop where I hope the participants must have learned a lot. It was a workshop on the case method, and 3 distinct faculties, two from IIM Ranchi and one from the TIS Mumbai, has taken the entire workshop. These 2 days, we have 16 cases that are to be presented, and these cases are all based on the theme of how the indigenous technology helped to combat or tackle the COVID-19 situation that prevailed in our country last year. So it has gone under a review, a blind review, and then multiple review, and out of that, 54 abstracts that were submitted to us. We shortlisted 16, and this will be presented in these 2 days. And out of these 16, those cases which are good enough, those are with very much having an approach to the real life, will be shortlisted for the publication in the book format. So this is the entire idea of ICMC, because cases are very important in today's life. So we have emphasized into it with the objective that down the time IIM Ranchi become one of the hub for the case study, and we are looking forward to it. And this is the first step to it. Thank you so much. And now I would like Professor Hazarika to take the stage and moderate the entire session. Thank you, sir.
Thank you, Sakshi. Moving ahead, in today's inaugural session, we begin with a lecture by our chief guest, Dr. Chandrakant Lahariya. Before he joins us on the stage and begins his presentation, we'd like to present a brief introduction of Dr. Lahariya, who has worked tirelessly on ideas to tackle the COVID-19 pandemic amongst the various challenges. So Dr. Lahariya is a medical epidemiologist and a public policy and health systems expert based out of New Delhi. He was a recipient of the R.C. Srivastava Foundation Award for his work on translating community-based health research into public policy interventions. He's a very prolific author and has a number of publications to his name. His latest book, Till We Win, India's Fight Against the COVID-19 Pandemic, has been released and discusses ideas on the lessons that we can take in fighting the COVID-19 pandemic and how it shapes the way ahead. So Dr. Lahariya, the floor is all yours. We would be happy to have you in any manner. You can follow any manner of speech as you want. If you could also provide a few minutes of time for questions by the participants at the end, that we'll be very thankful to you. The floor is all yours, Dr. Lahariya. Thank you.
Thank you very much, and good morning, Professor Sharan Singh, Director of IIM Ranchi, Dr. Sakshi, Professor Hazarika. and everyone who is attending this webinar. It's my pleasure and honor to speak here and talk a few things about COVID-19 pandemic and share my experience. So thanks again. And without further ado, I'll start sharing my slides and speak on the topic which was assigned to me. Can you see my slide? Can everybody confirm?
Yes, sir.
Okay. So,
It is coming.
okay, just give me a second then. Can you confirm once again?
Yes, sir. It is coming.
Yeah. Okay. Thank you. So thank you very much and good morning. So the topic which I'm going to talk today is looking back to look ahead. The learnings from COVID-19 pandemic in India. In this next 30 minutes or so, I would be highlighting what we have learned and what were the challenges and a few key aspects about the pandemic. Of course, I'll be touching about the first two waves and learnings and then what lies ahead in the future. I have a brief talk on vaccine, but we need to that pandemic are
Dr. Lahariya, we are unable to hear you. We have a slight bandwidth issue, I believe.
that we have evolved in this process. I a slightly rhetorical more ancestors are not more than 300,000 years ago. So viruses have been here for long. They have seen all the seasons, so to say. But more importantly, in the process of evolution, viruses have done one thing. They have shed the genes which they don't need. So they have simplified their life. While humans are becoming more complex, we need to really examine whether simplicity is evolution or getting complicated evolution. But viruses have been here, they are far more, and they are
Respected directors, sir, respected participants, we are just having a small pause.
Closer to the pandemic every passing day for 6 reasons minimum. One is that there is a faster mode of transport in the world, which essentially means that a human being can reach from one part of the world to the another part in less than 24 hours or so, which also means a pathogen can also travel that fast. So increasingly fast mode of transport is are ensuring that the disease spread will be faster. Second, we now live in the crowded, unplanned cities where there is a more contact between the people, and more the contact between the people, higher the risk of transmission. Then what we are doing to our environment, our forest, deforestation is essentially resulting in that there is a more contact between human beings and wild. What that means? It means that the pathogens and viruses which were till now in the wild are now getting in contact. And most of the recent epidemics and outbreaks have emerged from the wild pathogens or wild viruses which were not in touch of human beings till now, but in forest, the deforestation. And finally, there is a widespread use of antibiotics, antimicrobials, which is resulting in the
Dr. Lahariya,
development of resistance of these. Hello.
Dr.
Hello,
Lahariya,
yes.
yes, I just had wanted to say you something. Sir, there has been a bandwidth issue since the beginning, sir. We were not able to hear you for the majority of the time. I believe you will have to, sir, restart again because there is a consistent bandwidth issue, sir. We have only heard you for 30 or so seconds.
Hello. Hello.
Yes, sir. Yes, Dr. Lahariya.
You could not hear me from the very beginning.
Yes, sir. We were trying to reach you, but we could
Yeah.
not hear you from the very beginning, sir. Yes, sir.
Professor Hazarika,
Yes, sir.
should
Yes,
I
sir.
like
Sir, is the connection stable on your end?
my connection is fairly stable, but I really don't know. Like now I'm putting earplugs and let me see. Can you hear me now?
Yes, yes, we can hear you now. We can hear you now.
Okay, so I was not using earphones maybe. So shall I start from the very beginning?
We would recommend that, sir, because a majority of the part your voice was not visible and we are trying to reach you, sir. So
Okay.
we would like, yes, sir. Yes, sir.
Okay, let me reshare the.
Definitely. It's much better now. It's much
Okay.
better now.
Can you see my screen now?
Not yet, sir. We're waiting for it.
Okay, there is some issue, I believe. Stop because when I say stop sharing, share your preview, then stop sharing my screen. Let me log in again, maybe that will help. right? Okay.
Yes, sir. Okay, we are here, sir. Sir, we are happy to have you back.
This mute. And, yeah, okay. I was not able to unmute myself. Now it's better.
Yes, sir. Dr. Lahariya,
Yeah.
we believe that what we can see from our end is that there is a bandwidth constraint. What we recommend you, sir, is that you can send us the slides right at this moment and we'll project it on the screen. Or, sir, that you will have to turn off the camera for the moment and use only the slides, sir. So this is to just preserve the video bandwidth, sir.
Can it? Okay. So I have turned that video off. Hello.
Yes, yes, yes. You can now share the content, sir. I think it should be better now if you have turned off your video. We can see your screen, sir.
I'm not sure what is happening. Professor Hajarika.
Yes, sir. Yes, sir. We cannot see your
You can hear
screen.
me now. I'm stop.
Yes, we can hear you clearly, sir. We can hear you clearly. We can hear you clearly.
You cannot see my screen.
No, we cannot. We cannot.
Dr. Hazarika, if you have the slides, can you run the slides and let Dr. Lahariya speak?
Yes, that is
Kindly explore this. I think this will be better. Let his
yeah.
video and slide be off. Let him only speak and you run the slide. I think that will be a better idea.
Indeed, sir. Indeed, sir. Indeed, sir. Indeed. Dr. Lahariya, you're back now. Yes,
I have
so
shared the PPT also, so you can project from there, and here I stop video and we stop all the video, so maybe that works.
yeah, that will work, sir. Also, we are sending you the Cisco dial-in numbers in case you face any problems. We will, you can
Okay.
contact us and you can dial using your mobile phone, and then only your voice will work. So we are also sending you
Okay.
the Cisco dial-in numbers on your phone. Definitely.
Okay, I think I don't know why it was not working. It never happened, but let's start. Shall I share my slide, or if
No,
it
sir. We
doesn't?
will share. We will share, sir. We will share
Okay,
the.
sure.
You can just contact.
Mhm.
Give us a moment. We'll put up the slides on the screen.
Sure, please.
Definitely, sir. You can turn off your video and the screen, and we can then go ahead. Thank you, sir.
Yeah, thanks. My apologies for entire challenge. So I'm going to quickly talk about the topic which was assigned to me, looking back to look ahead and learning from COVID-19 pandemic in India. Next slide, please. One of the key things to remember is that in a pandemic, the fate of people and pathogen and pandemics are all related. Essentially, the term pandemic has originated from Greek root, which means pan means all and demod means something which falls upon all people. So pandemic is something which affects all people. And the pathogen is a common thread between people and pandemic to happen. Next slide, please. What we know and what we need to remember that majority of the pandemics happens due to viruses, but they can happen due to other pathogens. And in this process, we need to ask one rhetorical question to ourselves. Do humans represent the peak of evolution or viruses? And just to understand that, we need to remember that what is the total number of humans on Earth? That is 7.8 billion or approximately 8 billion. But when we ask how many viruses are on the planet, you can look at the numbers and you would realize that viruses exceed human beings by many, many, many folds. So if you will count these zero, the number of viruses on this planet are 10 to the power 31. So there are 31 zeros here. If you look at for every human beings, how many viruses are there? So the answer is, again, you will see 125 and then there are 21 zero after that. So viruses exceed human beings and exceed by many folds. And this is the number of viruses only. There are many other pathogens. So the bacteria are of nearly similar number as viruses, but bacteria on the planet Earth are slightly less than viruses. Viruses are tenfold more than the bacteria. And these are the estimates. But there is another thing. Viruses have been here on this planet for billions of years. They are part of the evolution of the planet itself, while human beings are here for 300,000 years only. So viruses have seen many springs, as they can say, or as we can say, and they have learned and understood and seen everything, and they have learned how to survive on the planet. One of the key things that as time passes by, humans try to collect things, they try to become complex. But viruses have done reverse. They have shed the genes which they never needed. So they have become simpler and humans have become complex. And that's a perfect regime for creating pandemic or starting the pandemic. Next slide, please. So in today's world, with every passing day, we are closer to the next pandemic than we were yesterday. And there are many reasons for that. We know in the last 2 decades there are a number of new and old diseases which have emerged and re-emerged. There are at least 6 broader reasons for that. One is that the world now has a faster modes of transport and more modes of transport than ever. So in today's world, a human or a individual can reach from one part of the world to another part in less than 24 hours. And that's exactly true for the pathogens the person can carry. So viruses or pathogen can travel from one part of the world to another part of the world in less than 24 hours. And that makes the spread of disease faster and gives a real potential of pandemic. Second reason is that the world is getting urbanized. And in this urbanization, there is a growing and there are crowded and unplanned cities. Essentially, all of this means that there is a more contact between the people, and pathogens require the closer contact between the people to transmit it. Then third part is that the human encroachment to the forest, the deforestation, the cutting, indiscriminate cutting of the forest, all of which we are doing in the name of the development, is bringing human beings closer to the wild. What it means that the pathogens or the viruses which were hidden till now in the forest are now being exposed to the human beings. So in the last 2 decades and the last many years, we have seen many pathogens which were unknown, which were hidden, but which were still around, causing newer diseases, and that's one of the reasons. So deforestation has another impact, and one of the impact is pandemics, epidemics. The fourth reason is the climate change. Climate change has many effects, and one of those is the effect on health of human beings and health of our society. Essentially, the climate change and global warming means the pathogen can enter in the new settings. Pathogen can infect newer people, and they can also survive longer because of the change in the temperature, which is slowly becoming more favorable for them. We know many pathogens require, or even vectors require 8 degrees Celsius to 32 degrees Celsius. So in all those settings where average temperature was relatively lower or different, are becoming more conducive to the growth of newer pathogens. Fifth reason is that there is a newer attention and approach on single animal livestock operations, which means like large battery farming, which means more animals, more pathogens on those animals which were till now not that frequent, and that is also contributing to increase exposure to the newer pathogens and human beings. And finally, there is a widespread use of antimicrobials. The indiscriminate use of antimicrobials in the treating health conditions which are not required. Use of excessive antimicrobials in the animals also, which essentially means a small quantum of those antimicrobials comes into the human diet and human food, and then human beings are also developing antimicrobial resistance. So there are many fold attacks from the antimicrobial indiscriminated use of antimicrobials, and then we all are getting antimicrobial resistance. In short, the antimicrobials which used to work on us for a particular condition will not work and are already not working on human beings. So all of these put together was a challenge that all of us are closer to a pandemic or epidemic we were today than we were yesterday. One of the key things which we also need to remember that outbreaks, epidemics, and pandemics are a very similar terminology. The only difference is the geographical spread. So these terminology do not reflect the severity of disease. A pandemic could be very severe or very mild. Epidemic could be very severe or mild, or outbreak. The same disease can cause outbreak, epidemic, pandemic, depending upon what geographical area is affected. So we know that initially COVID-19 was an outbreak when it started in Wuhan. Then it spread to some more countries, it became epidemic. Then when it spread to the large part of the world, it became pandemic. So the same disease is described in different terminology depending upon geographical spread. So what we know that every single day there are many outbreaks happening in one or other part of the world. Every month there are few epidemics happening, and each of those has potential to become pandemic. And the factors are on this slide. Next slide, please. With this, we well know, and we know a lot about COVID-19 pandemic. So I'll provide just a brief overview that 15 months of pandemic, where India and world is. Next slide, please. So this is an epidemic curve for 4 countries which were most commonly affected, and we have seen in this pandemic, and these are visible, that the United Kingdom had an initial, all countries have these initial, 3 countries have initial first wave, March, April. So United Kingdom had a first wave in March, then second wave somewhere November, third wave, and then they are on decline. Then Brazil has continuous transmission of disease at a higher level. This is a magenta or whatever color it is. United States first wave, second wave, and then a third wave which had which M shaped, and then a fourth small wave. India had only 2 waves, which were really far spread. India was fortunate in having first wave. By then, a number of countries had already witnessed 2 waves. And then before India, the United States had the worst pandemic, and the number of daily cases, this is a weekly average in what United States was around 250,000 a day, sustained for a few days. And then India witnessed its second wave, which was the worst ever in the world. We can see the slope, the way cases had risen, and then fortunately we are on the decline. So what this slide shows that pandemics are unpredictable. Nearly all countries are having more than one wave. All had these waves at different period of time. India had only one wave in 2020, but then 2021, the second wave which country witnessed was very different from the rest of the country. Next slide. So these are the daily new confirmed COVID-19 deaths, and in deaths also the similar pattern have been followed. Nearly all countries have been affected. India also witnessed a rise in the deaths, and country has reported more number of deaths in any part of the world than any other country. So this is the pattern on the death also, and we see the similar pattern as the number of cases rise, deaths increases. Thanks. Next slide, please. In the interest of time, I'll go a little faster because we have lost some time, and I would like to keep focus on it. So coming to India COVID-19 pandemic response and some of the early learnings, reflections, and possible solutions. Next slide, please. One of the key learning from the pandemic has that people's participation is a essential or key pillar of pandemic response and well-functioning healthcare services. We often think that health service is a responsibility of a health system, but we have seen that in this pandemic, a majority of the role is of the people as well. So we know that COVID-19 is a mostly asymptomatic disease. 80% of the people do not develop any disease. And even in those symptomatic, like nearly 80% of those are mild symptomatic, and then 15 to 20% are moderate to severe who require hospitalization. So essentially, to prevent the disease, the non-pharmacological intervention of face mask, hand washing, and physical distancing, these are based upon public health principle and scientific evidence, but ultimately these need to be followed by people, and so that's their role in preventing the spread of disease. And then health system comes through the increasing testing, conducting contact tracing, developing facilities for isolation and quarantine, and providing treatment services. But we know that this treatment, the second part, is only for 15 to 20% of people. Majority of the people, majority of the intervention need to be done by the people, and both need to work together. And if people do it really well, then the burden on the health system will be reduced. And we have seen this success of this people's participation or community participation and engagement in improved health outcomes. As an example, we know in Dharavi in India, the success is fully attributed because people volunteer to get early testing done. People adhere to those COVID appropriate behavior even though there were challenges. But also government also facilitated the essential services on those areas. It provided physicians and providers closer to the people, so people, when they need health services, they can access those facilities. The quarantine and other facilities were set up closer to the people. So essentially, the outcome or the essentially Dharavi in Mumbai became a success story because each of the side, people and health system, did their bit, worked together to fight the pandemic. While we have seen that in the much of the 2020, the pandemic was really at a peak and affecting many people in Europe and the United States of America, in spite of their best of the healthcare system, medical care system, because adherence of the people to the COVID appropriate behavior was relatively low. So unless people also follow the behavior, it does not work. So both of them need to work together, and that's the first lesson. Citizens follow COVID appropriate behavior, health system provide health services. And there is a potential learning from this this experience in COVID-19. We know that there are non-communicable disease burden across the country. India as a diabetes, hypertension. Now, majority of intervention to prevent diabetes and hypertension are also preventive behavior, healthy diet, regular physical activity, no smoking, moderate or no use of alcohol. So these four interventions are informed by the public health and scientific evidence, but these need to be adhered to by the people to reduce the burden of NCD. And yet there would be some people who would develop disease, and then they can be, the health system need to prepare to provide treatment to those people. So that's the key thing, that people's participation and health system gearing up can result in improved health outcome, and that's the first learning. Second slide, please. Next slide. The other key learning in the pandemic is a three-way partnership. This three-way partnership between policymakers, elected leaders and administrators, the technical experts, the medical and public health expert or other experts, and communities. So this is extension of the previous point. So policymakers, technical experts and communities need to work together to keep society healthy. Now, I would like to give an example that many of you would have heard, that in Sweden, the epidemiologists and health system were responsible for the pandemic response. The policymakers had a no-touch technique, like they gave a free hand to technical expert. And then Sweden kept the country open. They did not put any restriction or lockdown. Sweden was among one of the few countries, besides South Korea and Japan, which did not put lockdown. And they kept the society open, and the outcome was that Sweden had far more deaths and far more cases than their neighboring country, and their epidemiologists were fully in charge. Then another extreme is United States of America, for where much of the 2020 the political leaders did not pay sufficient attention to the technical experts. So the political leadership was more or less in charge, taking final decisions. And we know what happened in the United States of America. The many deaths, far more number of cases, situation has come control only in the last few months. And then there is a third example of South Asian countries, such as Thailand, Vietnam, where essentially the policymakers, technical experts and communities all contributed their bit. We know that South Asian countries, especially Thailand, Vietnam, learned from SARS in 2002 and 4. The mask wearing is a common practice. People adhere to government guidelines. And there are institutional mechanisms where all three works together. So these three examples of Sweden, technical expert-led response, United States policymaker-led response, and South Asia, working together clearly give indication that we need to work together if we want to make difference. Any one will be in charge, then it will be challenging. All three need to work together. The similar learning from this experience for non-communicable diseases. In the interest of time, I'll move quickly. Next slide, please. The other learning which we have realized that it's not about healthcare only, or it's not about medical care only. Healthcare should be seen as much broader. So medical care essentially is a hospital-based treating the sick. And we know that some of the countries which have struggled, European setups, United States, they have a medicalized healthcare system. Public health interventions, the preventive promotive advice, those systems and approaches are not there. So that's why they struggle in spite of the best medical care system. Medical care system cannot handle or is not the efficient way of doing it. You have to prevent the diseases, then only the system, medical care system can work. So we have realized that if we want to fight pandemic, the medical care system should be strong, but public health system, the preventive behavior, promoting healthy behavior, preventing disease, maintaining good health are equally important. And we need to work on that kind of creating healthcare system and not just a medical care system. Medical care system plus public health makes a healthcare system, and that's what we need to remember. The countries which actually fared well in pandemic response have a stronger primary healthcare system, such as one we have in rural India, but which are not well functioning, but they are designed to deliver preventive health services, outreach services. So they treat sick people also, but provide preventive promotive health advice. The preventive health systems are also quick to adapt to pandemic response. Pandemic has reminded us that health services are not about curative and diagnostic in the middle. Health services should be about preventive behavior like the face mask, hand washing, physical distancing. So these are preventive or promotive behavior, but also rehabilitative, palliative care, the post-COVID care. All of this need to be provided. So one of the learning is healthcare, not just medical care. Next slide, please. We have also seen and witnessed that for effective pandemic response, both government system and private healthcare system need to work together. We have seen that what is the risk and disadvantage of private healthcare system, but effective and well-functioning government system was the core of the pandemic response in the very beginning. Like last year, starting March till June, many of the private sector facilities were closed because there was limited understanding on what is happening on the virus. And slowly the private sector facilities started coming up. So the key learning is that you need to have a well-functioning government healthcare system to respond to such challenges. And then private sector provided very important role. It provided medical care, hospitalization services, but there were reports of excessive cost. And even the testing services were being overcharged. And the government had to put a price capping, apply stringent regulation. So in a mixed healthcare system such as India, both public sector and private sector are required, but there is a risk in the private sector that it can overcharge, it can devoid, or people with limited resources may not get those services. So government had to appropriately apply health regulation, but government health facilities should also be strengthened. And there is an important role of public-private partnership. None of the sector is alone can do enough. So the public-private partnership can be utilized for personal protective equipment. It was used effectively. The testing kits were developed, testing services were scaled up, and vaccine development is a key example of public-private partnership. So both systems are required, but government also need to strengthen health system, its own health system, which is really weak. Next slide. We also learned during the pandemic that we should not be looking at merely a biology and medical science, that hypothesis such as India has a high BCG vaccination and that's why there were less number of cases, or we have a baseline higher rate of infection and that's why Indians immune system is hyperactive and that's why we did not have a severe first wave. And those were the kind of hypotheses which undone some of the success India achieved in the first wave. We believe that we are protected because of too much of focus on medical thinking in the health services. We need to look at behavioral and social sciences aspect of disease conditions. We need to see how and why communities participated in response and could have participated. So it gives an important lesson that we need to move beyond biomedical approach to health and need to give more attention to social and behavioral sciences if we want to improve health condition of the people. Next slide, please. So quickly move with these broader learnings and interest of time, I'll quickly move to the vaccines. So vaccines have been a biggest silver lining in this COVID-19 pandemic. We know that the world will come out of this pandemic only when a large proportion of world population is vaccinated. At the end of it, everybody would need to be vaccinated. So vaccination coverage had to be more than 80%, even higher. And in this context, the world came together and the world's fastest research and development for COVID-19 vaccine started. Before these vaccines, COVID-19 vaccines, the quickest any vaccine was developed from the proof of concept to licensing or availability in market was mumps vaccine in 1960s in 4 years. So when in early part of pandemic, when people used to ask when the vaccine would be available, even the most optimistic person would have said that, okay, 18 months to 2 years. But we know that world could develop vaccines in less than a year since into the pandemic. Like the first case was reported 31st December 2019, and the first 2 vaccines were licensed by early December 2020. So in a year, world could develop 2 vaccines. In less than 15 months into pandemic. Pandemic was declared on 11th March 2020, and then since then exactly 15 months today. So the world has now 15 vaccines which either are partially given early use authorization or fully approved. So 15 vaccines have been developed in 15 months of pandemic. And this is really could become possible because of partnership between government, manufacturers, and other institutional mechanisms. I want to highlight one of the mechanisms which contributed to this accelerated vaccine development. Rather, there are 2 or 3 things which contributed to accelerated development. One thing is that some of the vaccines for COVID-19 have been developed on the platforms which have never ever been used for vaccine development. mRNA vaccine, which are Moderna and Pfizer BioNTech, on those platforms, vaccines have never been developed. But those companies, those platforms were in the research for many years and nearly 2 decades. And those manufacturers were working on a different vaccine. And when this new virus emerged, they quickly switched to develop this vaccine. So there is an advantage of having infrastructure and a research system which they could quickly utilize to develop a vaccine for a different pathogen. Similarly, in 2017, a global collaboration called Coalition for Epidemic Preparedness and Innovation, this is CEPI. This organization was created by WHO, Gavi Alliance, and some countries together. And role of this collaboration was to ensure that accelerated research on vaccines are done. So they started well before this pandemic was ever happened. So advanced planning or planning for the future gives a good insurance against possible pandemics and risks. So we cannot prepare for pandemics when pandemic hits you or strikes you. We need to prepare well in advance, and that's a key lesson. Third reason these vaccines could develop in quick fashion, because many of the processes, though all of the processes were adhered to, but many of the approvals which used to take a long time were given in the real time, and more than one stages of approval were given, but each of the process was followed. So world has 15 vaccines. There are many vaccines which are in research and development, and we can expect that another 10 to 12 or 15 vaccines will be available. Essentially, while there are many things which happen, which have affected adversely the entire world and everyone, but one of the silver lining is that vaccine research and development globally in this pandemic has leapfrogged by a decade. What world could achieve in a year might not have been possible in a decade or even longer. So it has leapfrogged really well. Next slide, please. India already has 2 vaccines in the use: Covishield, which is Oxford AstraZeneca vaccine, originally developed in UK, but being manufactured in India by Serum Institute of India, and that is also show the importance of collaboration. The vaccines are always developed between a government or academic institution and a manufacturer. That's essential collaboration for vaccine development. But UK vaccine being manufactured in India shows the global collaboration and how global collaboration can benefit the entire world. The second vaccine is indigenously developed vaccine by Indian Council of Medical Research and Bharat Biotech, a pharmaceutical company or vaccine manufacturing company. Covaxin, that is an inactivated virus vaccine, which means a killed vaccine, is a very traditional platform. Covishield or Oxford AstraZeneca is viral vector vaccine, again another new platform. That group was working on a MERS, Middle East Respiratory Syndrome virus, and when this new pandemic happened, they quickly switched to this virus and develop vaccine quickly. In India, the third vaccine, Sputnik V, made in Russia, has been approved and will soon be available available for administration. Government will decide whether in private sector or government. And there are many more vaccines which are in pipeline. India has provided in principle approval to all the vaccines which meet certain eligibility criteria, so they are likely to be available. So India would have more vaccines available in coming days. Next slide, please. Next. If we look at this slide, so this is the number of people who have been vaccinated with at least both people fully vaccinated in absolute terms, and of course, United States has vaccinated around 40% of their people with both shots of the vaccine, and this is a real-time data, and the graph you can see a really fast pace. India has, of course, done more vaccination than Brazil and United Kingdom, but still far below in terms of when it comes to both shots of vaccine. Next slide, please. If we look at the numbers in India, like in other countries, in terms of people partially vaccinated, people fully vaccinated. So India has, of course, exceeded the overall number of doses administered, but if we look at the number of doses, number of people who have received both shots is far smaller in India than other parts of the world. Next slide. So this is very good reminder and important learning for us that India is the world's largest vaccine manufacturer. But in spite of, in fact, India supply vaccines to nearly 70% of the low and middle income countries, because the number of countries which are vaccine manufacturers are less than around a dozen across the world. All countries do not make vaccines. So India makes vaccines. In the terms of volumes, India makes maximum number of vaccines across the world, and it's supplied to large part of the world. The vaccines produced in India are also low cost. But in spite of being low cost and a large volume vaccine manufacturer, India is struggling to deliver vaccine. There is a very stark learning that simply having capacity does not mean that you can deliver. We have seen similar thing in oxygen supply crisis in second wave of pandemic, that India had oxygen to a large extent, but still there was a crisis. So there are two learnings from this, and these are learnings which helps in managing any crisis, that there is no substitute for advanced planning. That's a broader principle for pandemic, but for specific things also, we should never take that because one has a capacity to manufacture vaccine or supply vaccine, it will automatically happen. We need to plan in advance for responding to a challenge. More specifically, pandemics can only be fought with preparedness, and unless there is a preparedness, you cannot, once in the pandemic, you cannot really handle it well, and impact would be very different. The second learning is, which is true for any other supply dependent aspect where product needs to reach to the people, but in the context of vaccines, there are three integral components. One is a policy and planning, second is assuring supply, and third is delivery. Each one of those are really important. So India spent, for example, a lot of time on doing planning and prioritization, that which vaccine, which age group will be administered by a vaccine. So they started planning in July and August, but it did not secure enough vaccine supply, unlike many other countries. India placed the first order for vaccines 5 days before the launch of the vaccination drive. So without assured supply, how vaccination can be done? And the outcome was that soon when people started demanding vaccine, there is a short supply. So in spite of being world's largest manufacturer, in absence of sufficient planning or securing supplies, we have more demand than supplies, and countries still struggling to ramp up the vaccination drive. And then third party delivery. We need to really plan really well. Delivery also need to ensure that the people who are most in the need receive the vaccine. For example, the CoWIN, the IT-based platform has been created, but which has been found to be rate limiting, because many of the poor people, those in rural area, those in tribal area, those in urban setup who do not have smartphone devices, were finding it difficult. So delivery should also be well planned. Each of the components should be given attention if you want to find an effective outcome. Next slide, please. In interest of time, I'll go a little faster and then maybe answer questions. So after two waves, what next? There are a few things which are, there is one thing which is being said that third wave is inevitable. There are some discussion on new strains and children. Next slide, please. So this is a slide from 1918-1920 influenza pandemic. In the slide, what they show, the various lines depicts the situation, or this is a second wave, or number of excess deaths per 1,000 reported in different parts of the country that time, British India, the provinces. What we see, this is on the left hand side, April to June, there was a first wave, And then August to December, there was second wave, and second wave was really very high and really worse than any wave in any part of the world. And 100 years later, India has really repeated, or the history has been repeated in India in a negative way, that we had faced the second wave, which was the worst in the world. Though pandemics do not follow the same pattern, but this COVID-19 and influenza virus both are respiratory viruses. What broadly understood about these viruses and behaviors, that once a new virus enter among us humans, it is likely to stay. So we know one thing for sure, that pandemic will be over. But even when pandemic will be over, the SARS-CoV-2, the virus which caused COVID-19, is likely to stay. It will become endemic. In 1918, 1920 pandemic, it took 4 waves. It's not fully depicted here, before the virus become endemic and still with us. The same is being expected. However, this virus is a little more tricky. So one thing is clear, there would be more waves as long as there are susceptible people, which essentially means there are people who have not developed disease or who have not been vaccinated. There would be cases which will emerge from different parts of the country, and there would be subsequent wave, third wave, fourth wave, or maybe fifth wave. But what is also being recognized, that before India entered into second wave, there were around 80% of Indian population which was susceptible to the virus. But in this second wave happening and large proportion of population getting affected, it is estimated, though we will know after the nationwide zero survey, which is being conducted, but it is estimated that around 40% of Indian population would still be susceptible. So unless vaccination is ramped up, there is a risk of some pockets where the virus can still emerge. Next slide, please. Previous one, please. But there are a number of factors which will contribute to third wave. So there are new and emerging strains. We are hearing that Delta strain, which was originally called B1617 or Indian strain, now called Delta strain, is a predominant strain in India, especially in Delhi and many parts of the country. Now this strain is 50% more transmissible, 50 to 70% more transmissible than the Alpha strain, which was originally found in UK. And the Alpha strain was already 50 to 70% more transmissible than the original strain, which was reported from Wuhan. So essentially, the Delta strain, which is circulating in India, is 2 to 2.5 times more transmissible than original virus, which was being circulated. There is also evidence that this virus has a Delta strain, new strain has immune escape, which essentially means that if a person has developed infection in the past, the person can still get infected with the newer strain, though the probability is relatively lower, but there is a possibility. And there are reports of that this virus can cause severe disease. Early indications are there. So with all of these factors, there is a risk that even if population is has developed infection in the past or immunized, there would still be some cases. And that it will, whether third wave will happen and when it would happen, the current estimates show that by November 2021, when the impact or the immunity provided by natural infection wanes off, and even those vaccinated in April, May might again at risk. So by November, the susceptible pool will increase, and we can see a third wave somewhere around November 2021 to March 2022. However, that will be dependent upon many other factors which I highlighted. So coverage of high-risk population will be the key. In pandemic, our focus is, of course, reducing the transmission, but the key focus is reducing mortality, hospitalization. So increasing vaccination coverage would be key, which will determine the when the third wave would happen and to what extent. But I can tell you one thing which is really assuring, that all estimates say that the subsequent wave will be far smaller than what we witnessed. But there could be a smaller waves in a state or which would be relatively bigger, but we don't expect, it is not expected biologically and immunologically that third wave or any subsequent wave would be as big as what we had seen in second wave. Next slide, please. So there are various variants which are circulating. One is there in India. There are total 10 variants. Next slide, please. And this is a data from Delhi which shows that in India, originally the different strains were circulating, but on this slide, last bar, component bar graph, you see the Delta variant has become the most common variant and which is the most transmissible and immune escape. So that's a challenge. And this is data for Delhi really recently, but we don't know about other setups and country and other setups in the country. And it is being estimated and based upon available data that Delta has become predominant variant in India. Next slide. But one thing, another discussion which was happening around the country that in third or subsequent waves, the children would be affected. In this summary slide, I want to show that this slide shows the disease distribution or the moderate admission between hospital admission between amongst the various age groups over a period of time when United States, this is US data, when United States started doing vaccination, and you would see each of the bar represent like a newer period. So what has been found on the right hand side that the population which was vaccinated or which started on the vaccination early, the hospitalization rate has just continuously declining in those population. What is very assuring that the children had been very low rate of hospitalization, and this continued to be low rate of hospitalization. So many people were saying that adults will be vaccinated and risk is on children is higher. But the point is that there is no risk of additional risk of children. Children are similar risk. There is no need of fear that children will be more commonly affected in the subsequent wave of pandemic. Next slide, please. Last few slides and then I'll close. After 2 waves in India, are we wiser? Next slide. There are many silver linings in this thing. Our attention on health has improved. There is a stronger deliberation to strengthen health services. Teleconsultation has become legalized in country. There is ramping up hospital beds, testing capacity, PPE kits, research and development has been boosted. There's a new partnership between the policymakers, health experts, and community members. So in spite of all the challenges, there are silver linings in this. Next slide. But one of the key lessons from the pandemic is comes from Angus Deaton, Nobel laureate, which many of you would be familiar, that which says in his 2013 book, The Great Escape: Health, Wealth, and the Origin of Inequality, Angus has argued that much of the development of European countries has come one after they are learning from cholera pandemic of 1917 and influenza pandemic of 1918-20, where these countries realized the importance of health and public health services, and the countries started investing in health. So Angus Deaton has argued that much of the economic growth and development in European nations is dependent upon their investment in health. And that's one of the lessons which India need to learn, that if you want to become an economic superpower, economic development can only happen when there is a healthy people, there is a human capital formation, and there is investment on health by the government. So that's a key learning. Any learning in the pandemic or pandemic response of India or world will be incomplete unless learnings are derived and actions are started on that. Next slide. So what are the other key learning? The key learnings are that prevention is better than cure. We need to invest in health systems. We cannot boost the health system only when there is a pandemic or epidemic or challenge. Healthier society needs three-way partnership. Public and private sector need to work together. We need timely and reliable data, strong disease surveillance system. Each of the Indian state need to learn, and entire world need to learn from each other. The world cannot afford to make mistakes. So there are some of the good practices and some of the failures in even within India and among the states. These states need to learn from each other and utilize that for a future response to any subsequent waves, but standing health system. Most importantly, we cannot be complacent, and no country can be fully prepared, and no country can be safe till the pandemic is over from all parts of the world. And to prepare a country from any epidemic, outbreak, or pandemic, stronger health systems gives opportunity to respond better. And we have seen in last 15 months or last 18 months that health and economy are so interlinked. Investment in health is investment on economy, investment in development of the nation. Next slide, please. And that is, thank you very much. Thank you very much for patient hearing. I have co-authored a book with India's two leading experts, Dr. Randeep Guleria, Director of IIMS, and Dr. Jagandeep Kang, who is a vaccine expert. Some of the points reflected here are also captured in that book. So thank you very much. I stop here.
Thank you, Dr. Lahariya. It was indeed a privilege to hear from you, and we learned so much from these slides. And we apologize from our end for the technical issue right at the beginning, but I think we have covered the time very well, in fact, with time to spare. So I now open the floor for questions, and in the time...
Sir Hazarika, can I have a question? This is Ashok,
yes,
sir.
please. Yes, please go ahead. Please go ahead.
Dr. Lahariya, I have one question for you. So much is being done with reference to treatment, with reference to the so-called COVID-appropriate behavior. There are hardly any reference to COVID-appropriate economic system and COVID-appropriate health management. We are only doing disease management. For example, our day starts with a cup of tea, which has sugar, which has milk, which has caffeine. Okay. And all three components are bad for health. Okay. And we predominantly eat wheat, which is hybridized wheat, which has amyloclatin A, which results in sharp rise in the blood sugar and sharp fall in the blood sugar, resulting in glucose imbalance. So why there is no talk about, good health in terms of food?
I think that's a very pertinent issue and point. And some of this I reflected in my presentation, that how the non-communicable disease, that you raised the similar point, that a lot of sugar, the caffeine, all unhealthy habits which we follow. And India is the diabetic capital and hypertensive capital of the world. And many of these can be prevented. But we also know that till now in India, our approach to health is that treatment of the sick people. We don't provide enough advice, or there are not enough interventions which will prevent and which prevents illness or keep citizen healthy. But it is also very challenging because adoption of healthier behavior for the people is ingrained in the societal and behavioral factors. So we grow in a particular setup. There is a culture of doing things. For example, if you go to any office, you are offered a cup of tea, and if you go to 4 places, that we offered 4 cup of tea, and then if you don't drink that cup of tea, then the people will be offended. So it's related to many aspects. But what we can learn from this pandemic, that if those kind of collaboration or partnership are started, where importance of preventive approaches, treatment services, and if we can derive some of the lessons, that how if people can adopt behavior of face mask, physical distancing, and hand washing, then probably we can do little more to adopt a healthier lifestyle. But it is also linked to alternative. For example, we can talk about telling people that live a healthier life or regular physical activity. But our cities are not designed for humans. These are designed for cars. So there is no footpath.
Dr. Laya, my second point was that COVID appropriate economic system. For example, we have centers of employment, and there is large concentration of population. People live in inhuman conditions. So don't you think we should also be talking about propagating, COVID appropriate or healthy economic system, or centers of value creation and centers of value destruction? So can we not spread economic activities across the length and breadth of the country, and not have these centers of value creation where people migrate in large numbers? We saw during the early pandemic how people were moving away from the so-called centers of value creation to their native places, and how so much of fatalities and helplessness emerged. So I think, should we not also propagate concurrent to the treatment? Of course, this is firefighting. Treatment is firefighting. But how to prevent this fire from happening?
Exactly. No, I completely agree with you. that something need to be done, and I think the institutes such as IIM or the partnership between the economic, the institutions, the policymakers, and health expertise, and that kind of partnership and those kind of thinking need to start, and that's how it will happen. It will be a slow process to change, but as you are saying, there are new proposals such as smart cities or state-specific initiative. Those need to be factored in. I believe that process will start, but it is suboptimal, and probably currently the challenge of COVID-19 second wave is far bigger. But if it does not happen, that kind of dialogue and discourse does not start, and that does not fructify, that will be really unfortunate. But I think this will start with the academia and subject expert taking that forward. And I agree on everything you are saying.
Thank you.
Thank you. So we are almost at the end of the discussion. Our respected director, sir, if you have any final words on the discussion today and the lecture by Dr. Lahariya.
Dr. Lahariya's lecture has been quite informative, and it is going to definitely give us a lot of lessons how to cope with the recent pandemic and prepare ourselves for the future. So it was a good. Thank you, Dr. Lahariya.
Thank you very much, sir. Thanks.
Thank you, Director, sir. Thank you, Dr. Lahariya. I think it has been a very, very enriching discussion today early in the morning, and we learned a lot from you regarding the pandemic and how the response has been till now and what we can do going ahead. And I think for most of us who are currently living this year or who are currently alive, this is the first major pandemic that we are facing, and nothing had happened before from where we could derive lessons. But I think this will be a lesson for the upcoming generations and the time ahead. So thank you, Dr. Lahariya. Thank you, respected director, sir. Thank you all the participants for joining us for this informative session today in the morning. And thank you to the organizers, Dr. Shakshi, Professor Mishra, and Professor Marathe of the Atal Bihari Vajpayee Center, and all the faculty members for their continued support, our respected director, sir, for his guidance and support throughout. And with this, we will conclude the inaugural session of the ISMC, and we'll move ahead with the first technical session where we'll have the presentations, and Professor Ankur will take it from here. And I believe that we will have a good learning experience for the next 2 days as well. So thank you, everyone, and thank you for attending the session. Thank you.
So there is a break in between, or you are starting?
Sir, there is a 15 minutes break. We start at 11:30, sir.